There's no simple solution. You can't deal with loss in codes. You have to break it down in terminology that the surgeon understands, meaning the same term, the colloquial term, whatever that instrument's called at your institution. Yes, there are some common terms, but there's also some variation from region to region and site to site, even within one system. I'll move from one hospital to another in my own system, and instruments will be called slightly different, names from one site to another within the same hospital system.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now it's time to roll back and start the first case.
Joining us now is Dr. Pearce McCarty, orthopedic surgeon and chief medical officer at DOCSI. And today we are really going to be addressing the topic of surgeon engagement and looking at it through the lens of efficiency in the OR and how engaging our surgeons and knowing how to best engage them can improve our efficiencies. We're also going to look at preference cards and some of the struggles that we have with our preference cards and how we can best work together with our surgeons to really improve them. And we're going to get some key takeaways from this conversation that you can implement today when it comes to communicating with your surgeons and initiating improvements. So don't go anywhere. We'll be right back with Dr. Pearce McCarty.
Hi, I'm Chris Blevins.
And I'm Melanie Perry.
From the studios of Healthcare HQ, you're listening to First Case.
Joining us now is Dr. Pearce McCarty, orthopedic surgeon, chief medical officer of DOCSI, and the medical director for the orthopedic clinical service line and the medical director for the supply chain at Allina Health in Minneapolis, Minnesota. And Dr. McCarty, thank you so much for joining us today.
Melanie, thanks so much for having me. As I was saying a little bit earlier, I really enjoy your podcast and have listened to multiple episodes. I think it's a really informative podcast. I learned some things. I listened to, for example, your suture episode, which I thought was fantastic, and excited to be a guest here.
I'm excited to have this conversation today. And I think that it's kind of fun as the nurse in the OR, the circulator, to get to ask the questions of the surgeon and be like, tell me how this works. Explain to me what's going on in your brain, or what are you understanding, or just to ask those questions, because all of us have them. And I think being able to hear from your perspective is the way that we learn and grow and the way that we make our operating rooms better. And today we're really going to be talking about efficiency in the OR and surgeon engagement, of course. And then also we're going to bring up the lovely preference cards that are always a source of frustration and concern. But before we dive into all of those very rich topics, why don't you take a minute and introduce yourself to everybody?
Love to. Thanks for the opportunity. Pearce McCarty. I'm a shoulder and elbow surgeon, orthopedic surgeon specializing in shoulder and elbow. As you mentioned, I practice in Minneapolis, Minnesota. I'm part of the Allina Health System, which is a 12-hospital system in the upper Midwest, covering south central Minnesota and far western Wisconsin. We are I would put us as a mid-sized progressive healthcare system, and I have been part of that system for now 15 years. So it's been a fantastic place to grow a practice and grow into leadership. As you mentioned, I'm one of the medical directors for our orthopedic clinical service line. We have about 40 orthopedic surgeons now, and then multiple primary care sports medicine physicians. Do a tremendous volume of cases across a wide gamut of clinical subspecialties within orthopedics. I kind of look at us as kind of the private-demic model. We do research, and we are as specialized as most academic medical centers. I also work closely with supply chain, and that gets us into the efficiency questions. So I deal with supplies, implants, cost, efficiency, inefficiency, most commonly, unfortunately. But one little bit that I usually mention in these types of situations is that for 13 years, I was a team physician for the Minnesota Twins. That's actually what drew me from Chicago to Minnesota. I was recruited to fill that role, and so spent a lot of my time around baseball, Major League Baseball for that matter. Went back and ultimately got my MBA at Duke. Go Blue Devils. I think we got a good chance this March, right? And then really got involved in leadership in a meaningful way. And what drew me into leadership, what drew me into entrepreneurship, DOCSI is a healthcare IT company that focuses on efficiency within the operating room and does so through digital solutions, was just my living the pain of the problem. Like yourself as an OR nurse, how many times have you been in the operating room and you didn't have what you needed, and so you had to run out while I'm standing there with my arms crossed and my foot tapping on the floor, counting the seconds until you get back and swearing it was at least half an hour since you left the operating room, even though it was 2 minutes, right? Or having things that you don't need and seeing that waste on the back table, whether it's open, not used waste, or you have this enormous bin of held items, none of which gets opened, right? Because the one thing that's not in the held items bin is the one thing that I ask you to go run for. And so invariably, when the circulator leaves the room is also when I need something urgently to be opened that is in the room, right? And so then we're asking the CRNA or the anesthesiologist to get involved or what have you. So kind of living the pain of that problem over many years inspired me to really try to be a more meaningful part of the solution. So that's a short background.
But I like that last bit because you dealt with frustration, which is frustration that we all feel, but you decided to become part of the solution and not just, suffering under the problem. And that's how we get better, right? So when we think of OR efficiencies, right, you've already talked about, when we talked before we even started recording about, those delays and those turnovers and just all of the different variables that can feed into inefficiency, and we want to change it to efficiency. So as a surgeon, where is it that you see our opportunities for improvement when it comes to improving efficiency?
I think one of the main areas or opportunities for improvement comes through communication. You mentioned that this is an opportunity for us to communicate, for you to ask me anything as a surgeon about what's going on between my ears and the OR with respect to efficiency. And again, I tell some of my surgeon colleagues when I'm talking about this very topic, no one shows up in the operating room thinking, whether it's a surgeon or a PA or a circulator or a CST, no one shows up thinking, I really want today to be slow and painful and inefficient, full of 2-hour turnover times and lost items and problems with SPD. Like, that's what I'm looking forward to today. No one shows up like that. And so everybody wants the day to be efficient. Everybody wants to provide excellent care for the patients. And so one of the areas that I don't see capitalized or leveraged enough is simply communication. One of the problems is that we're also busy. When does that communication occur? And that communication could be around preference card optimization. So let's take a look at the preference card. Let's see what's on it, what doesn't need to be on it that is, what isn't on it that should be. These sound like very simple things, but I guarantee that probably most of your listeners could walk up to their surgeons and say, when is the last time you sat down and reviewed your preference cards? And they would probably say, I've never done that. And it's not because they didn't want to necessarily. It's a very challenging process. I mean, we're a system that has implemented a large electronic health record system, Epic, which has functionality in this space, but often there are gatekeepers that limit accessibility, again, not for any nefarious reason, but just because that's the way the system is organized. And so having a way that everybody can get on the same page, almost like a huddle. Digital technology is great for this, and that's kind of where I'm going with this. A way to huddle and talk about what's needed before the case. Because when the case gets there, like it's too late. Like when you're in the middle of the case and you don't have something, which is always going to happen from time to time, but really should happen far less than it does right now, then you're already behind the eight ball, so to speak.
Yeah. You brought up something, and this is kind of a deviation from our topic, but it's not. But it's just one of my experiences as a circulator, because you talked about maybe huddling or talking ahead of time or finding out what's needed for the case. And I 100% agree. There are so many times I just want to know what the surgeon needs. What do you really want for this case? Your preference card says this, but is this really what we need? And more times than not, I'm met with irritation or frustration or impatience. And when reality is, I just want to make sure we have what we need. I don't want to run my tail off during the case, and I don't want the surgeon angry that I don't have what we needed. But how do we actually create that space where we can have those conversations and really get that information communicated so that we can have a better case?
Right. Great question. There are a few different ways we can create that space, a few different ways we can approach that conversation in productive ways. I think, first of all, we all know that there are multiple reasons why preference cards are inaccurate. And if you look at data studies, some studies by like Aorn, right, that are out there show that about probably 85% of respondents in one study stated that their preference cards were inaccurate across several different healthcare systems. And so the reasons are the following. One, they're not updated in a timely fashion. So it's the right card for that case, but it hasn't been updated, and therefore it's inaccurate with respect to supplies. Another is that it's the wrong card for the case. So often in many systems, there will be kind of a master card concept. And so let's talk specifics. Say arthroscopic rotator cuff repair, where there will be a shoulder arthroscopy preference card that has all manner of things on it, mostly in the held column. And they rely on kind of what I'll call tribal knowledge to know what version of that master card they should really pick for that specific surgeon for that specific case. So you have a shoulder arthroscopy card, you're doing an arthroscopic rotator cuff repair with arthroscopic subacromial decompression, and yet there are things on there to cover a lot of other types of shoulder arthroscopic procedures. So you rely on tribal knowledge. And what if the specific CST who has that tribal knowledge is not there that day, right? We've all been there. Then the case doesn't get picked correctly. And so moving on to kind of strategies or tactics that your listeners could use to broach this topic, one is, I would say, lean into the extended care team. So whereas the surgeon might not necessarily have time at the moment you have time to discuss that case, odds are that their PA or their nurse might have time and are going to be more approachable. Okay. And typically that's someone who's in the operating room with them and will have virtually the same level of knowledge as the surgeon in terms of what they're going to need for that case. If that's not an option, which sometimes it's not, depending on the size of the care team, approaching the surgeon themselves from an efficiency standpoint, I think is a reasonable way to do this. And in a way that, they can pick the time that they're going to respond. That can be challenging because I don't know about you, but most surgeons, my experience has been most surgeons don't respond to emails. It's not in a very timely fashion. It's
No,
as
they
if
don't.
this mode of communication doesn't exist.
Right.
And just so you know, I get it as well as a surgeon sending emails to other surgeons. So it's not that there's no power gap there that explains this inability to use email. It's something that's baffled me for a long time. But sometimes, you can do that and flag it in the subject line, important case supplies or something like that. And you might get a response. I don't want to, I'm sure there are several of your listeners who are kind of shaking their heads saying, oh yeah, that never works. And it doesn't work that often, but it's a low lift on your part to do that. And you might get a hit. So that can be a tactic. Obviously, there is, and I think this is most commonly what happens, there is that synchronous face-to-face communication that can occur at the beginning or end of a case. End of a case is best. Like beginning of a case, no, because the surgeon's focused on doing that case and getting things going. During the case, obviously not usually a good time. After the case, probably the best time, maybe even right before, right as the surgeon has scrubbed out, before they go talk to the family or move on into the next room if they have a swing room. I'd say the question needs to be as obviously focused as possible so that the surgeon can give a 1-2 word answer. Do you need X, Y, and Z? Yes, no. No, I don't need that. Or yes, I do. And hey, Dr. McCarty, real quickly, we just want to make sure that we're as efficient as possible for you. So can you tell me, kind of leading with that, we're concerned about your efficiency. So that then that's a very disarming approach to take. And especially as a surgeon, again, as I said before, everybody in the operating room is all about efficiency. And so if you approach me and say, hey, I'm just concerned about this being efficient. I want to make sure it's efficient for you. Can you just tell me this real quickly? And have it be a limited, don't make it an open-ended question. Hey, if you go and say, hey, can we sit down and review your preference card for this? The answer is probably going to be absolutely not. I don't have time for that. But if you review the preference card and you say, hey, Dr. McCarty, I need to know, do you need a 70-degree arthroscope for that case next Wednesday? I just want to make sure we have it for you and we're as efficient as possible. Oh, thanks for asking. Yes, I do need that. And granted, with some surgeons, you're going to get a little bit of a smart answer like, well, I always use it for that case, even though they don't. And, that's just the way it goes. But at least you have it, right? And Now, there is another way I'll just go over real quickly, which is there are some digital platforms out there which allow surgeons on their own time via mobile device in a prompted, guided way to review certain aspects of their preference cards. And it's quick and it's efficient, and that information gets fed back to the card manager so that they can then implement those changes in whatever EHR platform or card managing platform they may have at their site. So that's another way that can be done.
So actually, I'm glad that you brought that up, because one of the problems I think that we run into a lot with our EHR or EMR systems is terminology. And so the way the pref card gets printed out is not necessarily in the terminology that our surgeons, heck, it's sometimes not even in the terminology that I understand. And I was preference card manager when I was the team leader for orthopedics at an academic medical center. That was my job one of my jobs, to update those pref cards and keep them up to date. But when I would print them out and try to take them to a surgeon to go over them, it was like I was asking the English speaking surgeon to read French. Because the language wasn't the same. It wasn't understandable. It was more, we had what was called Lawson codes. And so you would have all the codes that were showing up. And so if you didn't know the code, you didn't really know what the product was. So maybe, I don't know if you can speak to the understanding level of it, but how do we actually make it where we're actually talking apples to apples and not apples to oranges when we're trying to get our preference cards updated and we want to work with our surgeons to do it?
Yeah, so I'm familiar with Lawson codes, and I know how confusing they can be. And I will say kudos to you for being a card manager, because that was you probably had allocated to you 0.1 FTEs, and it's like, or actually 0.01 FTEs time worth to do that. And it's like a 0.5 FTE job, right? So it's a lot of work. That is one of the many challenges that kind of pushed me on an entrepreneurial journey to create a digital solution that would simplify that, not only for surgeons, but for the perioperative personnel that have to manage that information on a daily basis. And I wanted to present that information in a way, as you put it, that is intelligible for surgeons. So calling items the same thing that they're actually called in the operating room. 99% of surgeons don't deal with Lawson codes, or whatever type of supply chain terminology is utilized, when we're talking about inventory and Workday or whatever platform is used to manage it. And also organize that information in the same way we think as surgeons or surgical staff or perioperative nursing, the way we think about cases. So grouping products into product categories that make sense intuitively, presenting them almost in the order in which they're going to show up in a given case, because that's kind of the way we think through intuitively doing a procedure. I'm going to need this thing at that point during this case, and I'm going to need this many of them. That led to creation of one of the digital platforms that DOCSI has. But I think in terms of just if we're not talking about digital solutions, if we're talking about just tactics that can be used tomorrow, in the operating room in a practical way, there's no simple solution. You can't deal with loss in codes. You have to break it down in terminology that the surgeon understands, meaning the same term, the colloquial term, whatever that instrument's called at your institution. Yes, there are some common terms, but there's also some variation from region to region and site to site, even within one system. I'll move from one hospital to another in my own system, and instruments will be called slightly different, names from one site to another within the same hospital system. You have to learn those, and you have to use that terminology with surgeons and really be ready. And also kind of, if the surgeon looks at you kind of with the head tilted, recognize, okay, I get it. This is not a term that you're familiar with, and it's not your fault. It's just a silly term, and I get it. It's not what we call it every day. On this platform, we actually use a lot of pictures as well, because if the name fails, you can often look at it and say, oh yeah, it's an Alice clamp. That's what that is. Yeah. Okay. Sure. Yes. We do need that tomorrow.
Yeah. I need that thingy. Yeah.
The thing that has the flat teeth and it clamps and it ratchets a little bit, and then right. Yeah. You can spread with it as well. I need that thing right there.
Yeah, that thing. No, pictures are helpful, and I can definitely see the value in more ways than one, really. I can see the value of having a digital solution, having something besides maybe just our printed out pref card that really does show pictures. How much easier is it when you're going through your pref cards to see what you need and what you don't, if you can actually see what you need versus reading numbers or reading descriptions or something. I can remember one time my director wanted us to take on a preference card project, where we were going to improve our preference cards and all this. Optimization is what it was called, preference card optimization. And I was required to print out all of the preference cards for all of my orthopedic surgeons and take them their stack of preference cards. And
how'd that go?
Yeah, it didn't, because they looked at this stack of like 45 preference cards or 50 or however many they had, and they're like, I don't have time to go through this. What do you want me to do with it? I'm like, well, I have to have your signature that says you looked at it. And he's like, okay. And they would sign them, and never actually looked at them. But I can see how daunting and overwhelming a large stack of paper, it was going to be like, I don't have time for that. So in the digital age that we live in, something bite-sized and easy, and I can take on as maybe I have an issue or whatever, I can see that being more helpful. And I can imagine from a surgeon standpoint that you're like, yes, give it to me in something bite-sized and easy, because that's what I have time for, right?
So, Melanie, when we really sat down and thought about what would be a way to present us as surgeons information that would be efficient enough that we would actually consume it and then do what you want us to do with it. And we really came up with 3 design principles around which we continued to work. One of those was that it had to be convenient, meaning it really has to be on my time when it's convenient for me. A second is that it has to be curated, meaning that I want to know that you've already gone through. You don't hand me a stack of 45 sheets of printed out preference cards and you don't know which ones are important, how many maybe I'm looking at cases I haven't done in 2 years. Why am I even looking at that? Has to be curated so that I know someone has gone through that and identified, either based on volume, case volume, or case cost, but they have some sound rationale for why you're asking me to look at this. And then the third thing was actionable, because if there's one thing I think any of us in healthcare get annoyed by, is when we're shown information and someone just says, oh yeah, I'm just giving you a heads up. I just wanted you to see this. Well, I mean, we make decisions for a living. Like, if you're going to show it to me, I want to do something with that information. I need to make a decision. I need to take action. So it had to be convenient, curated, and actionable. And when you combine those three design principles, then you create something that surgeons will look at. They'll consume that information quickly, and they will make decisions that are relevant to efficiency and cost containment in your organization. That's how we approach this whole problem, because I've lived through exactly the types of initiatives multiple times that you're talking about. And they are well-intentioned, but the tools that you have to accomplish those projects really don't allow you to accomplish them because they didn't exist.
Right.
And so we had to build them and then start to implement them.
I really like that convenient and curated and actionable points there, because I mean, I think that's true in a lot of different things. Even if you're talking about me and my time, I mean, I need it. My time is limited, as is everybody else's. And so when we're approaching someone about a new project or a new initiative or something that we need to tackle, whether we're reducing the size of our instrument trays, or we want to change our prep cards, or we want to have anything, which I've also been on an instrument tray initiative before, and that was very hard. But remembering to keep it actionable and really pointed and convenient, I think is a good frame of mind. But when we think about other ways that other initiatives that we have or other projects we're tackling within our operating rooms, we still have to drive physician engagement, or we still have to garner physician engagement. So how do we do that for our surgeons? What's the best way for us to either approach our surgeons or involve them in the things that we're doing so that they don't maybe come in and get blindsided by changes, but also are part of the process and part of the improvement?
So I think you can take those design principles, whether they are applied to a digital solution or they're just applied in a common sense way to approaching surgeons from an engagement perspective, and make them useful on a daily basis. I think the one other thing I would add to that is, and how should I phrase this, is really kind of giving surgeons or surgeon care teams a heads up that this is coming. And so, because the other, surgeons are among the most risk averse populations that you will find in what we do in the hospital. I'm sure you can find some risk taking surgeons outside the hospital, but inside the hospital, everything we do is really to mitigate risk in the operating room. How can I make this procedure as low risk as possible? Which means we also don't like surprises. And so when someone comes and out of left field says, "Hey, I have 45 pages of preference cards I need you to review," like, where did this come from? I didn't even know you guys were doing a preference card optimization. So leading into it, hey, sometime in the next 2-3 weeks, I'd really love to talk to you about this. If it's a preference card optimization, about several of your preference cards, which I think you would agree could be more efficient. We'd like to make them more efficient for you. And then you can kind of enter in. So you've given them the heads up, and they may engage at that minute in terms of, oh, well, when do you want to sit down? Right? Because they're not going to want to do it right then, most likely. Well, when do you want to sit down? And then, okay, well, we'll sit. When's it convenient for you? So then you enter into the convenient. Well, when is it convenient for you? Okay. Well, I can do it like next Thursday after cases. Okay, great. Oh, and Dr. So-and-so, don't worry. We've already gone through your cards, and we're really only going to focus on your highest volume cases, right? So now you've curated that information. We're not going to look at all your cases, because that case you do 3 times a year and the other one you do 5 times a year, like, who cares? We want to make sure we have the ones you do 150 times a year, like, dialed in, right? And so, oh, that's great. So 3-4 cards, yeah, that should probably cover it, right? And then when you have the meeting and you sit down and you've got this limited number of cards, or even just a few items on each card, not like we're reviewing the whole card, like whoever's doing this should have done the homework to say, if you track utilization in your operating rooms, not everybody has good utilization data, but if you have some utilization data, then you can kind of know that, right, these 3 sutures haven't been used, haven't been opened in the last 50 cases. And so you can take that curation step a step further, right? That action step further and apply it to the individual card and say, okay, we're really going to just talk about like these 3 or 4 things on these 3 or 4 cards because that's what we need decisions on. And then you ask, now we need a decision. That's the actionable part of it. And then the carry through is super important because as you know, the operating room is not a place of second chances. And so if the surgeon takes their time, sits down, they do this, and then they show up in a couple of days and nothing's changed, well, now you've probably lost their confidence in further action. So there is that carry through that's super important. And even letting them know, but you can couch that in some language that gives you some wiggle room, such as, thank you very much. We're going to implement these changes. Just so you know, the changes probably won't be implemented immediately, especially if you're at a metro hospital, because they have to be entered into Epic or Cerner or whatever your EHR is. And that can take, a couple of weeks. And then there are also usually some old pick lists that are still circulating, and we've got to get rid of those old pick lists because they tend to just kind of show up, and then we'll need to talk to the CSTs who work with you frequently who may think that their tribal knowledge supersedes what you just said. So just give us some space and grace. We really appreciate this input, but the changes might not happen instantaneously.
That is excellent advice. And I think you ended it well with that anticipatory guidance, because as nurses, that's something that we are entrenched in school is about, with our patients, right? And giving them the guidance for what to expect. And it applies to anyone that we interact with. So if we take on a project like preference card optimization, hey, here's how long it's going to take. Here's our goal. Here's what we're doing. That is where you maintain that trust. Yeah.
Set those expectations. That's right. Because the surgeon is going to think, well, I just made that decision. So tomorrow when I show up and do this case, it's going to be perfect, right? And so setting that expectation, like we really want it to be, but it takes time. And so work with us here and just so you know, so that they don't show up the next day and say, I just had a meeting yesterday and I told them I didn't need that.
Right. Yeah.
So I think that setting those expectations is key. So just to recap, right? So the tactics and applying these really digital platform design principles to everyday life, or maybe we're taking everyday life principles and we apply them to a digital platform. Sure. They work. And so first giving surgeons a heads up. This is what's coming. This is what I'd like to do. It's for efficiency. It's to make your life easier. And so when is it convenient for you? Okay, great. Now, when we meet, let me just explain. We've already gone through this. So we're not going to ask you to look at a lot of irrelevant information. We've already narrowed this down to what we think are the most important based on your case volume, the cases you do the most. There's some cost data in here that we have to pay attention to. And then we sit down, we go through it, and then you're going to make decisions. We're going to implement those decisions, but heads up, let me give you some expectations. It may take a little while for those decisions that you made, which we appreciate, to go into effect. And then you've got your surgeon engagement around preference cards, right? Around preference card optimization.
But that is a huge project that we tackle in our ORs across the country. It seems, on a constant basis. So that's excellent advice and a good takeaway and something that it's actionable. We can implement that and we can apply this to our practice. And so that is excellent. So
that's right.
I'm mumbling here, but yeah.
No, and there's another question I have been asked by some of our own nursing leaders in the perioperative space is, how in the realm of contract compliance, right? So on contract, off contract, supply use, maybe implant use. How can I approach surgeons about that? And I thought a lot about that. In my experience, the simple answer is don't. Because I think that is a minefield, right, that you really don't want to step into. And it's a question of cost. And a lot of surgeons are more than ever, tuned into cost implications of their supply utilization decisions, especially if you have a situation where a hospital or an ASC is a joint venture and they are owners in that. That is the one exception. I would say you could alert them to the costs of different alternatives, and they will probably be appreciative of that, as long as it's not right in the middle of a case, right? Never
Yeah, right.
in the middle
Never
of the case, it's just whatever they ask for,
Yeah.
that's what we're going to use. But in situations where they're not an owner of that facility, I would say the tactic is to engage the physician champion. There's almost always a physician champion for supply chain or for efficiency metrics in that given setting. And so if you recruit them to be your ally, let them know what your concerns are, then they will engage as a peer that other surgeon around what can be a very sensitive matter, especially when it comes to implant usage, right? So you, as an orthopedic nurse, when it comes to, say, total knee, total hip, implant usage, that is a challenging conversation for me to have with my fellow surgeons. So I would never expect a circulating nurse or a nurse director to have that conversation with a surgeon. I just don't, I can't imagine how that would necessarily go well.
Yeah, definitely. That is a really good takeaway as well, and something to remember. So we have run the gamut as I've asked you random questions about my experience, and they're not really so random because they're all tied to surgeon engagement and efficiencies and those pref card struggles that we all seem to have. And we've gotten some good advice and some good takeaways from this conversation. But if anybody wants to reach out to you or wants to find out more information, where can they reach you?
So if anyone has any interest in learning about what we do at DOCSI, they can go to www.docsihealth.com. That's DOCSI health.com. Or they could email me directly, and I'd be happy to get back to them at P as in Pearce, McCarty, MCCARTY, P McCarty at docsihealth.com. And we'd love to hear from anyone who thinks that this could be useful information, or if they just want to engage in a conversation around some of the tactics that I mentioned today. I'd be more than happy to have a conversation with them. We, do have implementation from coast to coast. We love learning from different perioperative experts and experienced perioperative leaders. It's one of the reasons we exist, actually, is to make their lives more efficient and make their operating rooms run more smoothly.
So you have heard it from Pearce himself, how you can get in touch with him, how you can find out more about his digital solution to some of these problems that we've talked about. But you've also gotten some hands-on takeaways and things that you can implement and apply in your operating room, no matter where you are. So Dr. McCarty, thank you so much for joining us today. This has been a very helpful conversation.
Melanie, thank you so much for having me. It's been a blast to be on your podcast, and I encourage and will continue to encourage all of our perioperative nurses to listen to First Case. It's a fantastic production.
That was Dr. Pearce McCarty, and we have had an incredible 35 minutes of getting to pick the surgeon's brain, so to speak, and trying to really learn how to best engage our surgeons, how to really communicate with them, and how to work together so that we can do things like improve efficiency, have more surgeon engagement. And also really, we did look at that hot topic of preference cards quite a bit, because that is something that we all acutely feel. It doesn't matter if we're the surgeon, the surgical tech, or the circulating nurse. We all struggle when our preference cards aren't correct. So looking at ways to improve them, looking at ways to work together so that we can make them better, because ultimately it improves our efficiency. It makes our workday better, and it absolutely translates into better outcomes for our patients when we are as efficient as possible. And that includes things like preference cards being up to date. So that is going to do it for this week's episode. On behalf of all of us here at First Case, thanks for listening to this week's interview.
Thank you for listening to this week's episode of First Case. As a reminder, you can help support us by subscribing to First Case on your favorite podcast app or by downloading the smartphone app on iPhone or Android. Simply search for First Case in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@firstcasemedia.com. We look forward to hearing from you.